Cancer is the scourge of the decade. Welcome to this session on anti-neoplastic drugs. In about 20 years' time, you people will look back at the current treatments for cancer and you will ask why. The answer will be they were all we had. We're going to look at these chemotherapeutic agents. They are cytotoxic in a lot of cases, and they have various adverse effects that make you ask why. We're already starting to see some better therapies emerge, and the answer to cancer will be known. We won't have to wait 20 years. The answer will come earlier than that. But let's look at the current treatment. First of all, the causes of cancer. You will need to read up more about this. I've only listed a few examples. You can see there infection is being seen as a cause of many cancers, a principal cause where if you can target the infective agent, you can prevent the cancer, and there's already one treatment available, a vaccine, to prevent cervical cancer. So there is also some cancers that have a genetic predisposition, or it might be another disorder, such as obesity or insulin resistance or a hormonal abnormality that not only predisposes to cancer but might be a principal cause. There are various toxins in the environment or in food, or it might in turn be a nutrient insufficiency that is the principal cause of a cancer. We're seeing more and more that stress is involved in cancers and may actually be a principal cause of certain cancers. And in addition, exposure to radiation will cause cancer. Chemotherapy treatment of cancer has been around for a long time. To use the term chemotherapeutic agent is a very broad term. There are about 100 drugs used across the world, and so you can see why we're only going to look at quite a small number of those and look more at the drug class and its adverse effects. So depending on what type of cancer the person has will determine what chemotherapeutic agent is used. Often it's a chemotherapeutic agent in combination with surgery or radiation, and also to get the best remission from certain cancers, agents are best used in combination. Chemotherapy targets particular biochemical pathways involved with cellular replication. This is hoped to cause selective cell death of only those cancer cells, and as we'll see when we look at the adverse effects, this selectivity is not always possible. The chemotherapeutic agents might act on initiating oxidative damage to cancer cells. They may damage the DNA of cancer cells, and they may prevent the cell division of cancer cells. Ultimately, these effects lead to cell death either by the process of apoptosis or necrosis. So with apoptosis, there is no release of the cellular contents and no damage to surrounding cells. With necrosis, there is actually, in the cell death, a release of the cell contents and perhaps other cell death as a consequence. Chemotherapeutic drugs target specific cancers. They control the tumour growth. They shrink tumours. So as we saw with their indications, they may shrink the tumour to a size to make the surgery or the radiation more successful. Chemotherapeutic agents may also be used just to relieve symptoms, such as the pain associated with the tumour because of its size. So here we're not hoping for a remission of the tumour, a remission of the cancer. We are just treating symptoms. Chemotherapeutic drugs might also be used as an adjunct after the surgery. Because they are systemic, they will target any microscopic cancer cells not only at the site where the surgery was done, where the cancer used to be, but they will also target any microscopic cancer cells that might have metastasized during or before that surgical procedure. There are various adverse effects to chemotherapeutic agents. Because most of them are cytotoxic, they kill cells and prevent cell proliferation, they will do this to normal tissues as well. The normal tissues that are most vulnerable: bone marrow, hair follicles, and the gastrointestinal tract epithelium because they're rapidly growing. Because they target these rapidly growing normal cells, they will cause alopecia, hair loss. Chemotherapeutic agents will also cause gastrointestinal distress, nausea, vomiting, diarrhea, and anorexia. The nausea and vomiting can become so severe that it in itself can become a danger, where the person might aspirate their own vomitus, and this would set up a pneumonia. The problem here is that the chemotherapeutic agent is also seriously suppressing the person's immune system, so they would be unable to combat that pneumonia because of that chemotherapeutic agent that caused that problem initially. The nausea and vomiting can discourage patients from continuing the therapy, and doctors might also need to discontinue therapy if some event such as a pneumonia occurred. The mucositis and stomatitis not only can affect the gastrointestinal tract but can be seen in the mouth and can cause the person quite serious concerns. The chemotherapeutic agent might also cause fevers and might extravasate outside of the vessels when it's being given by an intravenous solution. As it disperses through the tissues, it will cause necrosis of those tissues because it's a cytotoxic agent, and it will cause subsequent pain at that site. Chemotherapeutic agents also cause hyperuricemia because those cells that are damaged have to then be removed. The breakdown products of purine metabolism are uric acid from those damaged cells, and this uric acid gets into the blood, causing a hyperuricemia, and into tissues where it will cause symptoms of gout. So this will need to be treated with its own anti-gout therapies. Long-term, chemotherapeutic agents might have serious effects on the germ cells, and then once that therapy is stopped, there might be long-term effects, such as infertility. Mutagenesis of their germ cells might then result in problems when that person tries to then conceive or start their family. While a person is pregnant, cancer drugs are contraindicated. Most of them, because they're cytotoxic, are also teratogenic. There are also other specific toxic effects of certain agents on the liver, kidney, might be the heart, or it might be in the CNS, various neurological manifestations, and these will limit the dose of that chemotherapeutic agent. But the major adverse event and adverse effect is the bone marrow suppression. This will seriously limit the dose, and as we've seen, could lead to abandonment of the therapy if the person got an infection that could not be treated. The bone marrow is affected and suppresses white blood cells. This leads to leukopenia, low white blood cell count in the blood, and that's what leads to the serious infections. To prevent this, the person would be given transfusions. In addition, the chemotherapeutic agent will suppress platelets in the bone marrow and the proliferation of the thrombocytes. This will lead to a thrombocytopenia, a low thrombocyte count in the blood. This will lead to serious hemorrhage. Now, as we've said, the chemotherapeutic agent also causes inflammation in the gastrointestinal tract. These sites could bleed, and now you're seeing that those sites may not be able to clot because of a systemic lack of platelets. So in addition, a blood donation, particularly of the platelet product, can be given to prevent those serious hemorrhages. The chemotherapeutic agent will also suppress production of red blood cells in the bone marrow. This will lead to anemia. Doesn't need explaining, but I will anyway. So that's a drop in red blood cell count in the blood, and also an effective drop in hemoglobin as a result. So because they can't transport oxygen, the person is lethargic, and so on. There are many anti-neoplastic agents, grouped generally by their chemical class: alkylating agents, cytotoxic agents, miscellaneous types, antimetabolites, plant alkaloids, including the vincas, antibiotic cytotoxics, hormonal anti-neoplastic agents, and various miscellaneous anti-neoplastic agents. We won't have time. As we said, it's a very broad class of perhaps 100 drugs, so we'll only look at 3 classes and look at one key drug in each class. First of all, the alkylating agents. Cyclophosphamide is a good example. As the name says, these drugs alkylate chemicals in the cell, in this particular case DNA. This interferes with the unwinding of the DNA, and as you would know, to transcribe the DNA to RNA, a transcription bubble first has to form in the DNA from that unwinding process. If that is inhibited, then transcription to RNA is inhibited, and the cell is unable to make all of the enzymes that are needed to replicate the DNA. So ultimately, it interferes with cell proliferation by interfering with the DNA. The cell cycle becomes blocked at the S phase before the G2 phase. Cell proliferation is that mitosis where the DNA is separated into 2 new daughter cells, where each daughter cell gets an exact copy of the original DNA. So that DNA had to be replicated at some stage, and that was the S phase. The G2 phase is where all of the centromeres and other structures needed for mitosis are produced, but the alkylating agents block DNA replication back here at the S phase. So alkylating agents are indicated for acute chronic leukemias, lymphomas, multiple myelomas, ovarian cancer, and as we'll see, are used in combination therapies. The antimetabolite agents include, as an example, methotrexate. This particular drug is an analogue of folic acid. Folic acid is a vitamin that you need in your diet. To get it to work in cell maturation, it needs to be converted to tetrahydrofolate. The enzyme which does this is dihydrofolate reductase. As you can see, it's a reduction reaction because we're adding hydrogens to the folic acid. Now, methotrexate inhibits that enzyme, dihydrofolate reductase, and in this way prevents maturation of rapidly dividing cells. As such, it's indicated to treat breast, head and neck tumours, lung cancers, renal cancers, ovarian tumours, bladder and testicular carcinomas, acute lymphocytic leukemia, and non-Hodgkin's lymphoma. Of the hormonal neoplastic agents, we'll look at tamoxifen as a good example. Its mechanism of action is both as an agonist of estrogen and an antagonist of estrogen at estrogen receptors. So it's indicated in the treatment of breast cancer, especially in postmenopausal women, where that tumour is receptive to estrogen. That would be abbreviated OR, an estrogen receptive tumour, or ER if it's spelt without the O. Estrogen receptive tumours display the receptor for estrogen at their surface, and so you're providing a hormonal environment that does not induce the cell proliferation that is associated with estrogen attaching to that receptor. So in summary, many classes of drugs that are anti-neoplastic. We only looked at the alkylating agents, cyclophosphamide, antimetabolites, for example, methotrexate, and tamoxifen is a good example of a hormonal anti-neoplastic agent. But there are other cytotoxic agents that include the platinum compounds. They can be recognized by the platin in their name, cisplatin, carboplatin. There are many antibiotics which were shown to be too cytotoxic to be used to treat infections, so were developed instead to kill cancer cells. One particular example, anthracyclines. These bind to DNA, they inhibit DNA synthesis, and they also inhibit RNA synthesis. The vinca alkaloids include vincristin and vinblastin. Once again, their name gives you a clue. They are mitotic inhibitors. Colchicine is being explored as an antineoplastic from Colchicum autumnale. There are miscellaneous antineoplastic agents that are not cytotoxic. A good example here would be rituximab. Rituximab is an antibody. It's produced by genetic engineering, monoclonal antibody techniques and so on in large amounts, and it targets CD20 on B cells. And so it's particularly useful in certain cancers and transverse myelitis, other diseases involving B cells in the pathophysiology. Now, rituximab tends to be used along with giving the cancer the CHOP. CHOP is cyclophosphamide, hydroxydornomycin, one of the antibiotic type cytotoxic agents. O in the word CHOP is actually for oncovin, which is a proprietary name of vincristin. You'll recognize that as one of the vinca alkaloids. And then the P in CHOP stands for prednisone. As you read up on this, you'll see that steroids are also used in chemotherapy. So here we have a combination of an alkylating agent, cyclophosphamide, an antibiotic, hydroxydornomycin, the vincristin under the proprietary name oncovin, and prednisone, the steroid, hence the acronym CHOP. And CHOP used with rituximab produces good remission of myelomas and tumours where B cell proliferation is involved. So very broad class. Read up on the three major ones and mostly know those adverse effects: alopecia, the hair loss, the vomiting and nausea, which can be so severe that it requires treatment with antiemetics prophylactically before the chemotherapy is started. It can cause serious infections if inhalation of vomitus occurs. The other major effect is the bone marrow suppression of the use of antineoplastic agents, and that can also put the person at greater risk of infections, blood transfusions of white blood cells, and transfusions of platelets may be needed. The person will also be anemic, in addition to being at risk of hemorrhage and so on. So as an answer to cancer, a very toxic one, using less toxic developments such as rituximab, a monoclonal antibody, is reducing the levels of the other drugs that are needed, but what we want is a way of treating cancer that does not kill other cells, the normal cells in the gut, and so over to the future, perhaps in the future, a better answer to cancer.